You scratch your head, your patient is saying, well, really, tell me, what is my urticaria from? And you haven't done all the tests that Professor Benson talked about. You're like, I'm sorry, I don't know. And you are still having all these symptoms, but you know what? But we can still think about the treatment. Of course, you have to spend a lot of time talking about convince the patient that hopefully in our field is going forward in terms of still addressing the root of the problem. But we are in an area of very exciting research, and I hope to touch on some of that in my talk today. Here are my disclosures. So first, let's take a look at this. What is this? Looks urticarial. Well, as they say in Florida, the only thing itchier than mosquito bites is CSU. So while you're out here, watch out for the mosquitoes. So I want to start with a case here. So this is a 45-year-old female with 7 months history of itchy rash, and the lesions come and go within 24 hours, but they don't leave any residual marks. No prior work or treatment. Her itch is very significant, and she's been, as you can see, experiencing this for a while. And this may be a patient, you ask for risk factors, inducible factors, but you can't identify much, and that actually is likely the majority of our patients. And I felt so bad for the patient. Professor Metz talked about that. I had to warm up the yogurt, that's a really impact their daily life. But this is the case that we probably see more commonly in clinical practice. So when we look at urticaria and then we dichotomize into acute versus chronic based on 6 weeks, and then we look at if there are triggers, if there are known triggers, then you have the chronic inducible urticaria. There's no obvious external triggers, then we go to the chronic spontaneous urticaria. And then there are many ways it's important to look at to see how chronic spontaneous urticaria may present in different skin tones. And sometimes, for example, especially in richly pigmented skin tones, you may just observe elevation, right? So I think recognizing it clinically and how it may appear differently is important. Sometimes it can even have this EM-like appearance in our patients. So when we think about chronic spontaneous urticaria, a few things to note is that typically, as I talked about, more than 6 weeks is the chronic part of CSU, and then we think it's around 1% of the world's population. But we don't have too much confidence in the data. We think there's a little bit of variations in the prevalence, and we think there may be a 2-to-1 female predominance. And we're continually going to try to understand the epidemiology of CSU. A few things we've learned over the years, and again, these kind of observations, I feel like we need to refine it a bit more as we continue with this field. We understand that about half the patients tend to go into remission during the first 12 months, just without treatment. And when you're in the clinic, how do you know? Because you see these patients, you give your recommendation, and they actually don't come back, many of them, right? Half of them don't come back. And then why don't they come back to see you? Number one, they didn't like you. Or number two, in one way, it didn't recur. So we do see that. So this is important to recognize, actually. And then also about 11% of the patients will have symptoms more than 5 years. So there is a proportion of patients that will continue more than 5 years. And the diagnostic delays can really be prevalent in certain areas. This chart may look somewhat confusing, but it talks about how do you get to CSU and then how to distinguish it from the different other types of things that can look like urticaria. This is more for reference, but you do want to consider when you have the wheels. Are they on ACE inhibitors, for example? Have you ruled out hereditary angioedema? And and then finally coming down to chronic spontaneous urticaria. But there are other things that we do want to think about and make sure we do not miss in terms of when patients present with hives. Okay, so this is the European guidelines for evaluation of and the treatment of patients with chronic spontaneous urticaria. So let's take a look at this, and then I'll show you the Quad AI, the American one. The European ones, even though I'm not European, always have made more sense to me, to be honest. And I see some of the Europeans like, of course, in the audience. So let's take a look at this. So in all patients, hopefully, if you do identify triggers, we avoid them. And then consider second-generation antihistamines as monotherapy. If that doesn't work, you can dose up-titrate to up to 4 times the usual dose. And if that doesn't work, consider adding omalizumab to that. And the dose of omalizumab can be increased to 600 milligrams every 2 weeks. So the approved dosing for omalizumab in CSU, as we know, is 300 milligrams every 4 weeks in terms of the maintenance dose. But they said, you know what? If it doesn't work, you can consider going up to 600 milligrams every 2 weeks. And then if that still doesn't work, add cyclosporin on top of tricyclosporin, add that to on top of the second generation antihistamines up to 5 milligrams per kilogram. Of course, that's not a long-term solution for patients due to the renal toxicity. But this is the European guidelines. And then here's the Quad AI, the American guidelines. There are some similarities in terms of standards dosing of second generation antihistamines. But they say, well, maybe you should add, going up, maybe you should add a first generation at that time. Or maybe add a glucotriene receptor antagonist. And maybe add another H2. So there's some variability to what we do. And if you ask dermatologists or allergists, they have their own kind of favorite second generation antihistamines, and maybe do things a little bit differently. And then they say, okay, well then we add any of these other agents, omalizumab, cyclosporin, other inflammatory immunomodulators. Okay. So let's take a look at omalizumab here. How many of you are pretty familiar or use omalizumab in your clinical practice? Yes, I see hands raised here. And so as you can see here we're looking at the achievement of UAS7, which is a commonly used, as you know, scoring mechanism. So this is good control. 6 points or lower, and you see about half of the patients, right, achieving that with 300 milligram dosing. And then if we go to the absolute gold standard bar of UAS7 of 0, right, no urticaria, no itch, no hives of 0, and what you see is that about a third of the patients achieve that. You can see the placebo rates there as well. So this really kind of changed the field at the time in terms of, gosh, we can do something about urticaria, we can treat this. And one of the important things also in terms of later findings, so this is something that was published in 2027, looking at patients with chronic spontaneous urticaria and their IgE levels. And what they noticed is that the total serum IgE levels seems to correlate with response. So in patients that were treated with omalizumab, if you look at their serum IgE levels, what you see is that in patients who are complete responders or partial responders, they have higher baseline IgE levels compared to those who are non-responders. Perhaps not so surprisingly given omalizumab's mechanism of action being anti-IgE. Okay. Now, I think we're bracing ourselves for kind of groundswell of innovation and development in this area. And I think this is very exciting. cells can produce a number of different antibodies here in CSU. And you can have both type 1 autoimmunity with your IgE anti-autogens, and also you can have type 2 autoimmunity with your IgG anti-IgE, as well as IgG anti-Fc epsilon receptor 1 and 2. And some of the key cells that are in play include your basophils, of course, your mast cells, and your eosinophils. And I think we are continually trying to understand the pathogenesis of CSU as we are developing therapeutic targets. I remember when I was a medical student, I always thought, well, you need to figure out the pathogenesis first, and then you need to find therapeutics, which is true majority of the time. But sometimes you just throw the whole kitchen sink at a disease and see what sticks, and you're like, oh, I did not know that pathway is involved. So what are some of the unmet needs, right, in CSU? So let's think about this. We talked about we need more understanding of the etiology, and we also want to think about in terms of the symptom relief. How can we achieve better symptom relief? For the medications that we have, how do we think about the side effects and how to reduce some of the side effects? Long-term options, so if half of the patients resolve within 1 year, right? And then, so you want to think about the natural course of the disease. You want to, of course, naturally focus on those people who may have it beyond a long-term disease. And are the treatment options effective and safe for them long-term? And importantly, how long do you continue? How do I know when to stop? If they're well controlled, should I withdraw the treatment in the future to see if they've ridden out that wave already as well? And then also they all have this very prolonged diagnostic journey. How do we shorten that? And then of course access to specialists and who is going to own the field or not own the field, but in terms of taking hopefully, I'm foreseeing hopefully dermatologists will play a larger role in the management of CSU in the future. Okay, in terms of the upcoming therapies, I asked ChatGPT to create this wheel of fortune. Yes, and if you notice, if you ask, it doesn't really spell out the words exactly as you want it to spell. So there's intentionally put some misspellings in there. So, but yeah, there are a lot of things that are coming up. So here is a review article that looked at targets and then where the different therapies target in terms of CSU. And what you'll see is that there are a lot of different mechanisms people are working on. And whenever you see there are a lot of mechanisms people are working on, it's probably also a symptom that we don't exactly know what is going on, right? So we're like, you know what, let's try this and let's try that, and that's all part of the discovery process. So you'll see some IL-23 inhibitors, for example, of things that we case reports that were reported with some resolution. You see JAK inhibitors here. You see BTK inhibitors. You see our IL-4 receptor inhibitor, dupilumab. You see IL-5 inhibitors here, and you see also studied in situ, as was mentioned before. You have some of the anti-KIT mechanism that's being seen here as well. So when we're thinking about the novel therapies, they can fall into different categories. We have, again, the anti-IgE, the anti-IL-4 receptor alpha to be in a later phase, and BTK inhibitors, phase 3 studies, mast cell depleters, right, Barzo, and dupilumab, JAK inhibitors, and others. We have our IL-23s, we have our anti-TSLP, and then we have our anti-IL-5. So there are a lot of different classes that are at play here that are trying to target different areas this is looking at week 24 data. In the middle is UAS7, which, as you know, it measures the severity of the disease, taking into account both the itch score as well as hive score. This is where we're looking at reduction from baseline, and what we see here is that, so this is a change from the baseline. So as you can see, after 24 weeks, you can get about a 20-point reduction with regards to the UAS7 score compared to 12. So about more than twofold that of the placebo rates. And what about some other biologics here? So we have the anti-TSLP monoclonal antibody, and was found to have some improvement also. Tezepelumab in phase 2 study, and then we have some case series with IL-17 inhibitors. How about rituximab, our old friend here? And so what we see are some case reports there and some with Tildra. Okay, let's move on a little bit to another mechanism, our BTK inhibitors. So BTK inhibitors are important because BTK is involved in actually a number of different mechanisms when we look at urticaria. And BTK inhibitors have been studied and approved. There is approved in other therapeutic areas. Why it is important in CSU is because BTK inhibitors are involved in dampening the B cell activation process as well as activation of mast cells. And the furthest along, one of the furthest along is remibrutinib. And currently it's being studied at 25 milligrams of BID. And in the phase 2B studies, as you can see here, and I'll show you some data, the UAS is reduced, UAS7 is reduced by 83% versus 13%. So I'm going to show you a little bit more granular data here. Here is patients achieving UAS7, a score of 6 or lower, which represent, again, well-controlled disease. And so here what you see is at week 24, for example, over half the patients on this oral therapy would achieve a UAS7 score of 6 and below. And then what we are also seeing is the progression over time, right? So here we're looking at 52 weeks. So what you see is that we are seeing continued improvement. And here what we're looking at is a very stringent bar of UAS7 score of 0. And what you see here is that you can see after week 24 you can get continued improvement. Of course, after week 24 you do lose the placebo arm, but it's good to see the continued improvement, perhaps even just a little bit incrementally increasing improvement even following week 24. Okay, what are some side effects? Remember the unmet need in terms of mitigating the side effects. And what we notice is that overall, these are improved BTK inhibitors, right? So overall, we see a much improved safety profile compared to the ones that have been approved historically. We do see some PTPA that's been reported in the clinical trials for the remibrutinib, but mostly mild or moderate. Okay, JAK inhibitors. They are JAK of all traits. As you can see here, we have povorcitinib data. Hopefully we'll see more of that data coming from that. And then some pilot studies and news reports also with the JAK inhibitors. Mast cell depletion, anti-KIT, as was mentioned. So we do have programs that are ongoing with regards to these anti-KIT monoclonal antibodies. So definitely watch out for those as well. So perhaps in the future, this seems a bit futuristic that we will have personalized pathways. Right now we have an algorithmic approach, which is very helpful actually into guiding us in terms of therapy. But we will have, in addition to omalizumab in the future, likely dupilumab, likely we have our IL-5 also inhibitors, mast cell depletion happy that Indero Dermatology, I need to connect, I need to change I was searching on LinkedIn actually late last night. Oh my gosh, am I going crazy? Where did Innovaderm? Fortunately, they put Indero parentheses formerly in Innovaderm. So, and then really appreciate everything that you guys are doing in innovating not only dermatology but looking into the future, hopefully many other fields